Welcome to TCD with Tony. This is your introduction to TCD or Transcranial Doppler. Just a few disclosures to mention before we begin. I provide research support for Hope Kids 2 study, which is sponsored through Pfizer, TCD educator role through Nova Signal, and support through MUSC as a neurovascular sonographer. This intro to TCD course, we are going to review ultrasound history, background of ultrasound, background of transcranial Doppler. We will review TCD fundamentals, review of the spectrogram, M mode, everything that makes up TCD, the cerebral artery anatomy. We will review how to perform TCDs, and we will conclude with the tips and tricks of TCD. What is TCD? TCD is a transcranial Doppler. We are using pulse wave, 2 megahertz transducer, and we're insonating the vessels that are at the base of the brain in the circle of Willis. This is providing us information on how the blood flow is traveling at the base of the brain. We can see the speed of the blood flow. We can determine many things by monitoring the blood flow, and we can also determine if emboli is present. How did Doppler begin? Christian Doppler, basics of Doppler ultrasound. The Doppler is based on a physics principle called the Doppler effect. It was first described in the mid-1800s by Christian Doppler, and this describes how a sound wave frequency changes when it hits a moving object. In this case, a red blood cell is contained within a vessel. The ultrasound emits a sound wave with a known frequency. As this travels into the tissue and hits a moving red blood cell, the frequency changes as it reflects back to the probe. So based on this, the computer can determine the direction relative to the probe and the velocity of the moving red blood cell. Velocity measurements are also dependent upon the Doppler angle. With transcranial Doppler, we use an insonation angle of 0 degrees. That is the ideal angle for TCD. How did transcranial Doppler begin? TCD can be called the doctor's stethoscope of the brain. Since its introduction in 1982 by Dr. Rooney Oslid, it has evolved into a diagnostic, monitoring, and therapeutic tool. During evaluation of patients with acute ischemic stroke, TCD combined with carotid ultrasound provides physiological information on cerebral hemodynamics, which is often complementary to structural imaging. Currently, TCD is the only diagnostic tool that can provide real-time information about cerebral hemodynamics and can detect embolization to the cerebral vessels. TCD is non-invasive, cost-effective, and a bedside tool for obtaining information regarding the collateral flow across various branches of the circle of Willis in patients with cerebrovascular disorders. Advanced applications of TCD help in the detection of right to left shunts, vasomotor activity, diagnosis and monitoring of vasospasm and subarachnoid hemorrhage, and as a supplementary test for confirmation of brain death. How does the machine calculate the speed of the blood flow? TCD uses time average mean maximum velocity. The changes in frequency are plotted as velocities in real time, and that is what's giving us the spectral waveform. The envelope or white line over the top of the waveform is calculating this time average mean maximum velocity. The equation for the mean is the peak plus the end times 2 and divided by 3. And for the physics lovers, the Doppler shift equation is provided in the center of the screen. The pulsatility index. The pulsatility index is a parameter which correlates with certain pathologies. So we're looking for a normal range of 0.8 to 1.2. So we're looking at the resistiveness of the vessel. So you can see on the left the normal PI, that waveform. The PI equation is the peak systolic velocity minus diastolic velocity divided by the mean. The pulsatility index will give us an indication of disease, either proximal or distal to the artery that's being evaluated. So it is referring to the resistiveness of the vessel to give a sample of the differences of what the pulsatility index looks like when it is elevated or decreased. The first picture on the right for low pulsatility index or a PI of 0.4, you can see that there is higher end diastolic velocity. The trough is 50% of the peak. And this happens in situations such as hyperemia, vasodilation, tumors, AVMs, and post-stenotic flow. The second picture for high PI, this one is 2.0. This is increased resistance. This is an elevated PI. It's a pre-stenotic waveform. You can see this before a stenosis. You can see this when a patient has increased intracranial pressure, extrinsic compression, and vasoconstriction. Your last picture here on the right, another picture of a high PI, this is a 2.5 pulsatility index. This is severely increased. This is a pre-occlusive waveform. You can see this before an occlusion. If you do see this type of signal in all intracranial vessels, this can suggest cerebral circulatory arrest or a brain death. This is severe vasoconstriction. How can I tell if the mean velocity and pulsatility index are accurately calculated? This is the envelope tracing, which calculates the mean velocity and pulsatility index automatically. So you need to look for an accurate envelope tracing to know that your mean velocity and pulsatility index are accurate. If you look on this image on the left, you can see the white line over the waveform. That is the envelope. We need to ensure this looks like the right side where it is tracing that waveform accurately. The one on the left needs to be remeasured manually to create an ideal or accurate mean velocity. The last thing we'll look at on the spectral waveform, along with the mean and the PI, is the systolic upstroke. A systolic upstroke is the initial slope of the velocity spectrum during systolic acceleration. A delayed systolic upstroke indicates proximal obstruction, and a brisk systolic upstroke indicates the absence of any significant inflow disease. So you can see on the bottom right, this waveform is a normal waveform with a normal systolic upstroke. A systolic upstroke ideally should be 90 degrees in a normal patient. When a systolic upstroke is delayed, as it is here on the bottom left, this is a delayed systolic upstroke. This usually indicates a proximal obstruction or a narrowing of some sort before this waveform is found. Where did Power M mode begin? Mark Moehring invented Power M mode in 2002. Now this has 33 sample gates. Power M mode is an overall view of many depths. Previously, we've been analyzing one specific depth at a time. Now with the addition of Power M mode, we can see many depths at one time. We can see 6 centimeters more of intracranial space We can see a broad range of vessels at one time. What is power M mode? M stands for motion for M mode, and power M mode is an addition of seeing many depths. We can see 64 millimeters of depth with showing the amplitude and direction of flow in all of these vessels. The screen starts at the skin surface at top, and then as you travel deeper within the M mode, you're traveling deeper within the base of the brain. So hats off to Mark Moring for this great addition to TCD. This is providing much more information that is available to us when we're scanning. We can see blood flow from 64 millimeters, this huge range of red blood flow is the blood flow coming towards the probe, and blue blood flow is the blood flow going away from the probe. With previous information of one depth at a time, this was a huge improvement to transcranial Doppler. A little more on power M mode. The brightness of the M mode signal corresponds to the amplitude of the signal. So as you can see, the brighter the signal, the more red blood cells are being reflected. This also will show you the different depths that are equivalent to an adult patient. So you can see here 30 millimeters to 40 millimeters where this ultrasound probe is insonating. This is your middle cerebral artery, and this is the segment of the middle cerebral artery called the M2 segment. As you travel deeper within the base of the brain, from 40 to 50 to 60, this is still your MCA. This is your M1 segment of the MCA. You can see where it's meeting another vessel here. This is your MCA-ACA bifurcation. And then your ACA comes forward, and then that's where the ACOM is in the center connecting your two ACAs. So you can see the depth where this is located at on an average adult. This is 75 to 80 millimeters. So keep that in mind as your normal midline on your patients when you see the M mode. When you watch the M mode, you can see 280 and 90 at certain situations. And when you can see that deep on the M mode, realize that this is the other side of the head. The NovaGuide and Lucid systems use 2 megahertz probes and digital processing to provide the user with a map and image of the blood flow. So in the power M mode, we can see here the x-axis demonstrates time and the y-axis demonstrates depth. This is in centimeters per second, and also there is a frequency shift to determine when emboli is present. Reading M mode during TCD. This image can help explain what your spectral waveform will look like as you change your depth when scanning TCD. This green line along the M mode will show you the depth that we are insonating below. So we are starting on the left at about 40 millimeters, and we are taking this sample volume and we are increasing our depth to 50 and to 60, and about 60 or so is when we are meeting the MCA-ACA bifurcation. So that blood flow in red in M mode is coming towards the probe. It is above the baseline in the spectrogram. Once we meet the MCA and ACA, we have flow above and below the baseline. The blue is blood flow going away from the probe and below the baseline in the spectrogram. So we're getting the MCA-ACA bifurcation here around 60. When we travel deeper, we are isolating the ACA alone, and that is why the spectrogram is fading on the MCA and becoming stronger on the ACA. So the benefits of M mode are aids in window location. You can easily identify where the window is when you use M mode because you're not looking at one depth, you're looking at many depths. It will help with vessel identification, and it does account for varying head sizes. You will have to pay attention to your patient's head size to know what depth that you will be incubating the bifurcation. When it is a smaller head size, the MCA-ACA bifurcation will be more at 58 or 60, and when it is a larger head size, the bifurcation may be at 62 or 64, 65. In pediatric patients, the MCA-ACA bifurcation is commonly at 52 to 56. So just be aware of your patient head size, and the M mode is very helpful in determining what vessels you're incubating dependent on your patient head size as well. The last thing that M mode is excellent at is verifying when emboli is present, because you can see the emboli travel in time as a slanted line in the M mode. We have reviewed the history of TCD, history of ultrasound, fundamentals of TCD, and the breakdown of the spectral waveform, the layout on the machine itself with the M mode. Next, we're going to review how to perform TCD. How do we perform TCD? We typically begin with the transtemporal windows. We have transtemporal, suboccipital, submandibular, and transorbital. We will begin with transtemporal. TCD temporal windows. As you can see in the image in the center, there are circles around where the most common temporal windows are located. Window 1, right in front of the ear, if you place the probe here and you angle the probe towards the patient's eyebrows, this is where you will find your middle cerebral artery. Window 1 is the most common window identified in your adult patients. Window 3 is the second most common window. And then also for your challenging patients, windows 2 and 4. Now, depending on what window you use will depend on how you angle your probe, accordingly to where your intracranial vessels lie at the base of the brain. If you have your probe at window 1 and you're angled anteriorly towards the eyebrows, sometimes you're angled a little bit superiorly, sometimes more anteriorly. You're following your MCA. When you're angled anteriorly and you have your MCA, what you'll do is center your probe to obtain your MCA-ACA bifurcation. From there, sometimes you are angling slightly superiorly to identify your ACA, and then you are rotating your probe almost as a small comma posteriorly and inferiorly to identify your PCA. If you are obtaining your terminal ICA, you will angle inferiorly from your MCA-ACA bifurcation. Fortunately, TCD does have its limitations, and one of the biggest limitations is getting through the temporal window. So with the skull thickness on different nationalities and female versus male, there are limitations that take place. On average, elderly African American females will typically have the most difficult temporal window to intubate through. There is another limitation with attenuation of the ultrasound beam. As ultrasound travels through the bone and the soft tissue, it will diminish. So these are different factors to consider and to know when you are providing TCD. The most common vessel to begin with is your middle cerebral artery. It is the largest artery at the base of the brain and should be the easiest one to identify. It also lives at the most superficial depths than all the rest of the vessels, so that is one way to determine if you have accurately identified your middle cerebral artery. Now, 60% of the carotid blood flow will be carried through your middle cerebral artery. It is the largest of your vessels in your circle of Willis. You will find your middle cerebral artery at the depths of 30 millimeters to 60 millimeters. And you can see it here in the diagram. This ultrasound probe is on the right side of the skull. You can see the right vessel going out there. That is your middle cerebral artery. You can see that it has different branches. So your MCA, M1 segment, it will branch into your M2. And when it branches into your M2, there may be 2 different M2 vessels. So that's something to keep in mind when you're at that superficial depth of flow. Sometimes you may find it going towards you, or sometimes a little bit going away from you, or the gaps in the M mode if there is tortuosity of this vessel. You can see also the front of the skull here, your ACA with the arrow is colored in blue, and then you can see your MCA on your other side of the head. The middle cerebral artery. So the middle cerebral artery is mostly identified when you see that large, broad range of red within the M mode. So I can't help but think of big red gum from when I was a kid, when I tried to describe the middle cerebral artery. You want that big red broad band in your middle cerebral artery to show from 30 to 60 millimeters in your M mode. Sometimes it's 40 to 60, but you do want to see that broad range of red, the big red, to identify your middle cerebral artery. Now, the middle cerebral artery feeds the bilateral anterior cerebral hemispheres. It does have 2 segments that can be evaluated with TCD, the M1 and M2 segments. Blood flow in the M1 segment is traveling toward the ultrasound probe and will be identified in red in the M mode. And the M2 segment, as mentioned previously, can be identified with 2 different directions of blood flow. Most commonly, though, it will be coming towards the probe, so you will see red throughout the whole length of the MCA as we do here in this image. Here we are identifying the MCA on a TCD dedicated Doppler machine. We'll first review the parameters on the machine before scanning, ensure your parameters are where you want them to be, and then we'll place the probe at window 1, which is the most common for our adult patients, and angle towards the opposite eyebrow to isolate the middle cerebral artery. Once you find your middle cerebral artery, you will want to optimize your signal. Never settle for that first waveform, but always search for your highest mean velocities to ensure nothing is missed. Next, we are going to review the ACA, or the anterior cerebral artery. Now, the ACA lives at a deeper depth than the MCA. It lives at the depths of 60 to 75 millimeters. The mean flow velocities within the ACA are 55 plus or minus 11, and the blood flow will be going away from the probe. It'll be in blue in normal patients. So the anterior cerebral artery feeds the mid-frontal hemisphere of the brain. Blood flow originates from the internal carotid artery and travels away from the ultrasound probe, and that is why we're seeing it here in blue. So to help you remember, because I need things to help me remember, so I'm trying to make this a little bit more helpful for you. We're going to name our ACA Boy Blue. I don't know if any of you have seen the movie Old School, but we'll just use Boy Blue as our ACA to help us remember our MCA as Big Red and our ACA as Boy Blue. The best TCD landmark is where the MCA meets the ACA. Big Red meets Boy Blue. This will reorient yourself when you're scanning and you are not sure what vessel you're in, where am I scanning? You can go back to your MCA ACA bifurcation to reorient yourself to continue on to verify the location you are scanning. So the MCA is seen here, big red, 30 to 60, and there's your boy blue, ACA, 60 to 70. Next, we'll review the terminal ICA. So the terminal ICA is typically found at the depths of 60 to 70 millimeters. You will find your MCA ACA bifurcation first and angle your probe inferiorly or somewhat towards the chin and isolate that terminal ICA. The mean flow velocities are generally 61 plus or minus 16, and the flow is typically towards the probe, so it'll show in red in M mode. A lot of times when you see the terminal ICA, you see it as it appears here. It is almost by itself. You're angling inferiorly and you're getting that red band, and you can idealize it as the red rooster in the middle of the road. If this can help you remember what your terminal ICA will look like frequently in your M mode. Now, the terminal ICA provides blood flow to the anterior circulation as well as the posterior communicating artery. The posterior communicating artery will bifurcate off of your terminal ICA just before your MCA ACA bifurcation. And as we said, the blood flow is traveling towards the probe and will be red in M mode. And it is possible for the terminal ICA to be going away from the probe, but this will usually occur when you are angling much more inferiorly. The PCA, or posterior cerebral artery. Now this vessel will live at a depth of 60 to 70 millimeters, average mean flow velocities of 39 plus or minus 10, and it will be coming towards the probe. When you are looking for your PCA, if you are at your MCA ACA bifurcation, you will do a slight rotation posteriorly and inferiorly. It's almost as a small comma rotation to switch from your anterior to posterior flow. What you will see frequently is what we see here in M mode. This is your P1 segment on one side and your P1 segment on your other side of the head. So we are seeing the midline posteriorly here, and as you can see in the M mode, that midline is at 70 millimeters. So we are locating the depth of 60 millimeters in this specific picture, and we have our PCA identified in the spectrogram. The PCA, as you can see in the artery on the left, it will come off of your basilar artery. So your basilar artery will bifurcate into your PCAs bilaterally. The PCAs feed the posterior hemispheres of the brain. The blood flow originates from the vertebral and basilar arteries. The blood flow is traveling toward the ultrasound probe, and therefore there will be red band representing the PCA1 segment. The PCA2 segment can be found after isolating the PCA1 segment. Before inseminating the PCA1 segment, initially you would identify the MCA ACA bifurcation. After identifying the MCA ACA bifurcation, you'll rotate your probe angle slightly posteriorly and inferiorly, almost as a comma, from the MCA ACA bifurcation to the PCA P1 segment. You will continue to angle your probe more posteriorly when you want to identify the PCA2 segment. It is a more drastic posterior angle. when comparing to the MCA-ACA, and it is even more posterior when identifying the PCA1 segment. So what you will find when you identify the PCA2 segment, it will be the only vessel on the screen. The PCA2 segment is its own plane. You will not find the PCA1 and PCA2 in the same plane when scanning with dedicated Doppler TCD. You will find your PCA2 segment from the depths of 60 to 70 millimeters with your average mean velocities of 40 plus or minus 10. From this angle at the temporal window, the blood flow will be going away from the probe and it will show as blue in the M mode and below the baseline in the spectrogram. The posterior cerebral artery 2 segment will feed the posterior hemispheres of the brain. The blood flow will originate from the verts and basilar arteries, traveling away from the probe, as we said, showing as blue in the M mode and below the baseline in the spectrogram. Comparing anterior and posterior signals. It is always good to have a side-by-side comparison so that you can easily identify when you are looking at anterior versus posterior flow. Now, on an average patient, you can see very big differences when you're looking at these pictures side by side. Your middle cerebral artery here you can see has a mean flow velocity of 91, and you can see the big red band. Big red, 30 to 60. Now the PCA is a lower mean velocity of 32, and you can see that little red band, and it is a bit deeper, as you can see on your M mode. It's going from 60 to 70, where it's meeting your contralateral PCA. So we have the depth here on the right at 70 millimeters, which is the midline of the head in this patient, and you can see the bilateral PCA's P1 segment there in the spectrogram. So you can see the big differences, the differences in M mode, the differences in the spectrogram, the waveform difference, the MCA waveform versus the PCA waveform. And as you scan further, and you will identify the different sounds that you will hear in anterior versus posterior flow. Next, we will locate the submandibular window. So when we are doing patients for vasospasm, we need to obtain a Lindegaard ratio. That Lindegaard ratio is used to determine true vasospasm versus hyperdynamic flow secondary to the treatment that subarachnoid hemorrhage patients receive. So here is what you will look for when you're trying to locate your extracranial internal carotid artery. You're going to look for that solid blue band in the M mode. Your internal carotid artery is typically a lower resistive vessel, so you will have a solid blue band in the M mode, and this is displayed accurately in the center of our screen here. If you do see an image in the M mode that has black between the blue and the pulsatility index is higher, as you see in the bottom right, most frequently this will be your external carotid artery. So just look for that when you're scanning in the submandibular window. What you'll do, as you can see on the bottom left, is you'll put that probe just underneath the jaw and you'll angle superiorly straight up to the top of the head and isolate your internal carotid artery. How is the Lindegaard ratio calculated? As we mentioned, the Lindegaard ratio is helping us determine if the blood flow is fast only at the base of the brain. If it's fast at the neck and the base of the brain, you know it is fast everywhere. It's hyperdynamic. So we want to confirm if we do see elevated mean velocities at the base of the brain, we want to confirm that this is truly vasospasm and not secondary to the treatment received when an inpatient post-subarachnoid hemorrhage. So when you look at the screen here, you can see your middle cerebral artery, the mean flow velocity is 91, it's circled here, and that's what we're obtaining here with TCD. And then we're also putting that probe at the submandibular window. And we are getting our extracranial ICA so that we can compare the two. The Lindengaard ratio is taking the middle cerebral artery, the highest mean velocity, and we are dividing the extracranial ICA into the middle cerebral artery to obtain a ratio. And our ratios usually indicate vasospasm beginning at a ratio of 3. And of course, the higher the ratio is, the more severe the vasospasm is. We will continue on next and scan the vertebral arteries and the basilar artery through the suboccipital window. You can see on the picture here the suboccipital window. So with TCD, we're using different windows to identify the vessels. That is why we're putting this probe in these different locations. So what we're going to do with our suboccipital window is slide that probe just up underneath the skull and angle towards the nose and the eyes and isolate our vertebral and basilar arteries. Our probe placement is shown here. So you will have your patient supine with the head rotated slightly and the probe just underneath the skull. You can feel with your fingers where the skull ends before you place that probe to help you find that window easier. So you'll slide that probe underneath the base of the skull and you'll angle it up towards the eyes or the nose, depending on the patient's anatomy. You will first isolate your vertebral artery, and then you'll continue on to your basilar artery. The suboccipital window is very position dependent. There are times that I have scanned and you just can't find the suboccipital window. Your probe is not lined up accurately. In situations such as this, reposition your patient. Sometimes it's easy to slide the pillow up when you are scanning an inpatient just so that you can slide your arm up underneath the back of the head easily. Sometimes you can just have your patient's head turned a little bit to the right or the left so that you can get behind the head. Sometimes the patient's head straight, and with that pillow slid up behind the head will position that probe the best. It will just depend on each position, and these windows you can see here on the left image show your left, middle, and right suboccipital windows. Most frequently, you will use your lateral windows versus your mid window on your adult patients. Now, if you have been performing carotid ultrasounds, then you already know that you can see frequently a larger left dominant vertebral artery when comparing the right side. So when you are scanning your vertebral arteries and your basilar artery with TCD, this can guide you on probe placement. So with 70% of the population having a left dominant vertebral artery, you can see the image in the center with the probe lined up in the left suboccipital window. You will not have many rotations or angles to adjust. You won't have to move your probe much at all when continuing from your vertebral to your basilar artery. So this is common. If you do struggle with getting your basilar artery from the right, it is always good to try from the left side in case that patient has a left dominant vertebral artery. The intracranial vertebral arteries. You can see the location on the diagram where we are incubating. This is just before it becomes the basilar artery. So the depths of the vertebral artery are 60 to 79 millimeters, and the mean flow velocities are 38 plus or minus 10 on a normal patient. Now with that probe up underneath the base of the skull and angled towards the top of the head, that blood flow typically on a normal patient is going to all be going away from the probe. So you're going to see a broad range of blue when you're scanning your vertebral and basilar arteries. Now, the intracranial vertebral artery originates from the subclavian arteries. Blood flow is traveling away from the probe, and the M mode will display in blue. Isolating the basilar artery. So once you have your vertebral artery, you can continue on to your basilar artery. You can see the location on the diagram here. It is a large artery at the back of the neck, back of the head. Now the average length of the basilar artery is 30 to 31 millimeters. So our depth, when we find the basilar artery, it begins at 80. So the main indication you will know that you're in the basilar versus the vertebral is when you're looking at your depth. Once you reach 80 in an adult, you have reached your basilar artery. So if you begin at 80 millimeters and your average length of your basilar artery is 30 to 31 millimeters, this means the average basilar artery should end at 110 or 111. So you can find the basilar artery up to 120 on some patients, but just beware on some patients, if you're at a depth of 120 millimeters, you could have far surpassed your basilar artery and have continued on to anterior flow, and you could be insinuating your ICA. So in this situation, you would look for a gap in the M mode in the blue, and you would see a different waveform as you travel deeper through that suboccipital window. Here is a comparison of verts and basilar side by side, just so you can get an idea. We are seeing a broad range of blue in the M mode for both vessels, and we are seeing the verts from 60 to 79 millimeters. If you do ever need to get an extracranial vert, 45 millimeters would be a good depth, or 50 to get an extracranial vert if your physician is asking for a posterior ratio. Your basilar artery, as we mentioned, is identified at a deeper depth than your vertebral. You will find it at 80 millimeters and on to about 111 or 120. The mean flow velocities are usually a little bit higher in your basilar versus your vertebral, and the average means are 41 plus or minus 10. As we mentioned, you will see blue in the M mode when scanning the vertebral and basilar arteries. Just one point to mention to be aware of, because I have seen this on many occasions. When you are scanning posteriorly in your suboccipital window and you are at the depth of 60 millimeters, you may see red and blue at this location. And this is common because you can find the vertebral atlas. The vertebral atlas is where you see the curvature of this vertebral artery before it becomes that mid-segment and before it joins the basilar artery. So beware that there is the chance that you will see red and blue at 60 millimeters with the flow still looking normal, but this is just the anatomy of the vessels. Now here is what a dominant left vertebral looks like on TCD. So if you did a side-by-side comparison of a patient with a dominant left vertebral artery, you can see that strong signal on the left here. Your mean flow velocity is 38 centimeters per second compared to your right vertebral artery here is 23. You can see the right is a weaker signal and you have less blue in the M mode. So this tells you here that it is a dominant left vertebral artery. Next, we will discuss the transorbital window. So the orbital technique, as you can see here, is you're scanning over the top of the closed eye. Most commonly, you are placing that probe directly over the center of the closed eye when you're looking for your ophthalmic artery. So your vessels that you will insunnate through your transorbital window are your ophthalmic artery and carotid siphon. The probe is placed over the center of the closed eyelid to obtain your ophthalmic artery. Your ophthalmic artery lives at the depths of 40 to 60 millimeters, and it is a highly resistive vessel. You're feeding a high resistive vascular bed. So on a normal patient, you're going to see those little spurts of red in that M mode. You can see black in between the red. This is a high resistive vessel. You can see your PI here on the screen is 1.29. A normal ophthalmic artery has a high PI. So it has a low mean. This one's 19. This is normal. PI 1.29. This is normal for your ophthalmic artery. In this M mode, you can see your ophthalmic and your siphon in one image. Now, your ophthalmic artery will feed the orbit. It is the first branch of your ICA, and the flow is towards the probe in a normal patient, and it will produce this type of red intermittent blood flow in the M mode. Moving on to the carotid siphon. The carotid siphon lives at the depths of 65 to 75 millimeters with the mean flow velocities of 41 plus or minus 11. Now with the siphon, it is a curvature, there's curves, it's a tortuous vessel. So it curves just behind the eye, as you can see here in this diagram. So because it does curve, you can find blood flow towards the probe or away from the probe, and it's just going to depend on what segment that you are insunating on if you're getting the red or the blue blood flow. What have we learned so far? Transtemporal window vessels. We look at the MCAs, the ACAs, the terminal ICAs, and the PCAs. The submandibular window vessels, we look at the extracranial ICA, and we do that for the Lindegaard ratio. Our suboccipital window vessels are the basilar and vertebral arteries, and our transorbital window vessels are the ophthalmic and carotid siphon arteries. And you can see them all displayed here in the diagram on your right. As we mentioned previously, there are many different types of TCDs that can be performed, from sickle cell to vasospasm for subarachnoid hemorrhage, emboli monitoring, OR, tilt table testing, vasomotor reserve, brain death verification. There is a quite large variety of TCDs that can be performed. Just to note, there are certain things that may be apparent when you're incidentally when you're performing exams. An example is, say you're performing a TCD for vasospasm and you have an incidental emboli. How this is going to appear on your machine is, you'll see here on the left, it will appear as bright white lines in the spectrogram, and they will line up with the M mode. Now these lines are going to be within the waveform and within the M mode. You'll see a slight slant of the white line in the M mode correlating with the dot in the spectrogram. You'll hear also a snapping, popping type sound along with seeing the waveform and the M mode brighter concentration of line. You may also see bruits when you're scanning with TCD. You can see that on the top right corner here. You will see that within every waveform. You can see each of those waveforms, there are some higher concentrations of white within the base of the waveform. The bottom right corner is an artifact. When patients move or speak, any different multiple reasons, you will have artifact. You will see lines outside of the waveforms, and outside of the M mode. So this is just an overall view of the different things that you can see as you're scanning TCD and to be aware of. Here are a variety of different TCD dedicated Doppler machines and a couple thrown in just for fun. Whichever you choose, please ensure your diagnostic criteria is accurate and perform correlations with other testing modalities. There can be some slight differences from machine to machine, so just be aware of how your machine performs and how it relates to your other testing modalities. Make sure the information is equivocal, and this is just to maintain the best possible patient care. Lastly, we'll review some tips and tricks of TCD. These are just some things to keep in mind. It's always good to have a good connection with your hand on the probe and the patient's head. So a lot of times I'll have my pinky on the patient's head, touching the head itself, so that I have a firm grasp on the side of the patient's head. So when they move their head, my hand is moving along with their head, and I'm able to stay on the vessel, and I won't lose the vessel with patient movement. Another good thing to never forget is don't settle for those mean velocities as soon as you put the probe down. Always angle and search for those high mean velocities. You can't fake a high mean velocity, but you can miss a high mean velocity. So search around, find those high mean velocities on all of your patients. From window 1, always angle anteriorly to find the MCA. If the probe is set flat to the head, a lot of people will just put that probe down flat on the head to begin. That's commonly the PCA that you'll find. So get in the habit of putting that probe in front of the ear at an angle anteriorly to begin with so that you can identify that MCA. When there is a difficult temporal window, increase the power and the sample volume. These are tips that can help when all else fails. If you do perform emboli monitoring, if you're doing that on PCAs for verts or baselers, for dissection or anything with the vert and baseler, ensure that the patient doesn't have a fetal origin PCA. So a fetal origin PCA is when the PCA is still originating from the ICA. So it would be pointless to monitor the PCAs in situations for verts and baseler on patients that the PCAs are coming off of the ICA. Always obtain a good patient history prior to TCD exam and review the CTAs, MRAs, and angios. It's always good to have a good knowledge of what is going on with each of your patients before you walk in the door. If performing a PFO study or emboli monitoring study, ensure an echo with contrast, Lumicon or Divinity was not used. If this contrast is used, bubbles can stay in the system for 24 hours. So you'll want to schedule your TCD 24 hours after echo with contrast or do your TCD before echo. Correlate your TCD findings with CTAs and angios to ensure your diagnostic criteria is accurate. You can always adjust your diagnostic criteria if you see there's a lot of discrepancies with the diagnostic criteria that you are using. Keep slow, steady hand movements and maintain contact to the patient's head. And always watch the mean velocities while you're scanning. And when you are doing your findings, always do a global outlook of all of the mean velocities to guide you for your interpretations. That is the end of the presentation for today. Thank you for your time and attention.